Next up is Sally Satel, scholar at the American Enterprise Institute and staff scientist at the Oasis Clinic, Washington, D.C. And Sally's written widely on issues ranging from addiction to other health issues as well. And the reason I read that little thing about the American troops, by the way, was I was thinking about Peach's talk coming up and thinking about how you actually integrate into societies and so on, in case anybody missed the point of what I was trying to do there. It wasn't just a little Brit promotion. Sally Satel.
Thank you, Roger, for the invitation. I guess after Peter's talk, we'll go from social flourishing to individual flourishing. And that happens to be an interest of mine because I'm a psychiatrist and we work at the level of the individual. I happen to work specifically now. I used to be a general psychiatrist, but now I work part-time in a methadone clinic where opiates are, in fact, the opium of the masses. And where I have in my office a sign that says, "Abandon dope, all ye who enter." So why do people see psychiatrists or therapists? Well, basically to attain human flourishing at the individual level, of course, my level of focus. And that kind of help takes various forms. At its most basic, I suppose you could say, it's symptom relief. And I'm not really talking so much about the major mental illnesses in the remainder of my comments, but clearly that's a very important role for psychiatrists, and we work on relieving symptoms, psychosis, but depression and anxiety, the kind that are much more widespread, because those limit human potential significantly. We want to change behavior if that's what a person wants. They'd like to be more assertive so they can get a promotion at work. That's something we can work on. Another reason some people come is to attain insight and self-understanding. And one of the main reasons people see psychotherapists, I used to do that, I don't do that much anymore, but it's because they know they're sabotaging themselves so often in work and in love relationships and in other social realms, and we work on that. Any and all of the above purposes that people hope to, purposes that therapy serves are all are all prerequisites for human flourishing. I should say, is there a role for medication? Because that sometimes comes up as in opposition to human flourishing, that somehow if a person takes Prozac as opposed to resolves problems independently, that's somehow a less legitimate form of self-improvement. Well, I certainly don't agree with that. I feel anything that can help impart a sense of control through symptom reduction, or often in the case of drugs like Prozac and other SSRIs, it's really tweaking temperament, if not gross symptoms of depression. But I take a very utilitarian approach. What else can you do when you work in a methadone clinic? The idea is to set the conditions for human flourishing. Is methadone a crutch? Damn well is. But what's the difference? Because when you work with these folks, the question is always, what's, compared to what? And it's better than a needle in your arm, and so many of our folks do have quite productive lives. So even though the word flourishing an addict may not see, or recovering addict might not sound like it goes together at first blush, it very much can. But the essence of, I keep mentioning human flourishing because it goes back to, I can't recall, one of the speakers earlier talked about, what do we mean by the essence of human flourishing, and it coincides very nicely, again, with what a good mental health professional should do, which is expand the choices that people feel they have with a sense of agency, effectiveness, competence, control, kind of psychic mobility and autonomy. Those words are almost all interchangeable, overlap tremendously. Ultimately, that's a key to combating demoralization and learned helplessness, which probably have very, very profound effects on constricting human flourishing. Now, one of the problems is that actually some of the things we do in psychiatry and mental health, I find in some ways actually impedes agency and flourishing. And I want to give, the example I want to use to illustrate that is how we, as a field, the mental health field is sprawling. I mean, it goes all the way from counselors whose training is really at the master's level, and it's really kind of a pyramid in terms of both level of education and also just the numbers of the population of these helpers out there. But counselors, social workers, PhDs, and psychiatrists, you can argue they shouldn't, psychiatrists and psychologists might vie for the top. There just are more psychologists, and so they would fill that part of the pyramid. But a well-trained psychologist is absolutely wonderful. They can't prescribe, but they certainly, that is a limitation. So anyway, what are the ways in which the mental health profession can actually impede flourishing? And I mentioned I was going to focus on the area of traumatic response. And I'm going to talk at first about 9/11, the response of the mental health profession to 9/11, which is far more interesting than the response of the average American to 9/11. And then I'll move on to the kind of trauma in a pathological sense that we hear about more today, which is the kind of post-traumatic stress disorder that people who've been in combat can experience. Now, one thing that I've noticed about my profession is that it often assumes a presumption of fragility. The word panty waist comes to mind, that after 9/11 there would be a mental health crisis. You may know that over $150 million was spent setting up clinics, setting up infrastructure for all the psychic fallout that was going to come. There was going to be an epidemic of post-traumatic stress disorder. I'll just fast forward to the answer. It didn't happen. Granted, if you were in the burning building and just escaped with your life and experienced that kind of threat, you certainly had a much higher risk. But even then, although there's no data from 9/11, Oklahoma City bombing data, which are quite excellent, done by Carol North, interviewed every person who was escaped from that building. I believe there were 108 of them. And about a third developed post-traumatic stress disorder. I believe most people know what that is, but that's a psychiatric syndrome that's characterized by intense re-experiencing bad dreams, intrusive memories of the trauma, kind of phobic avoidance of reminders of the trauma, and just a hyper-arousal, a lot of anxiety. And it, it's a normal response often to calamities, but typically resolves over time. The APA just put an arbitrary limit of 30 days. If these symptoms persist longer than 30 days and you suffer impairment from them, it affects you so that you can't work as well or function in daily life, then you have a pathological disorder. And, that's a different discussion about how we formulate diagnoses and put boundaries around them, but I think that was a reasonable decision. So my point is, even among folks who are experience the worst kind of threat, still there is no guarantee that most will go on to develop this syndrome, and in most cases those who do it resolves. But that is not the way so many folks in the mental health profession saw 9/11 and often see PTSD in general. They were convinced, as I said, there would be this outpouring of pathological response. They engage often profligately in a tendency to misidentify normal sadness for pathology. A therapy called critical incident debriefing, maybe you've heard of. It's basically a kind of group session where folks sit around and discuss the worst aspects of their trauma and relive it. And it's turned out that now there have been a number of studies on that. It actually, frankly, it's an inert therapy for most folks, but for some it actually intensifies symptoms. So this is and it's still being practiced, and it's still a very profitable private. People make money off offering these services. So this is all very problematic in terms of seeing this kind of event as, there are three ways you can respond to these kinds of calamities. They can be seen as a loss or a threat or a challenge. And unfortunately, the mental health profession tends to emphasize the threat and loss dimensions of these and far less on the challenge. And the reason why that is so important is because post-traumatic stress disorder, I mean, it's not like schizophrenia or the more traditional mental illnesses. The essence of PTSD is essentially a fear reaction that hasn't extinguished. That's the essence of it. And that's very real, and there are excellent desensitization therapies that one can use, and some cognitive behavioral therapy as well. As I said, most people it resolves, and some it doesn't. But a very, very important part of traumatic response is that the way a patient and a patient meaning just someone who's come to the attention of a doctor, and a person meaning someone who hasn't. There's enormous overlap between those two populations, and an interesting side question is why some people decide they're going to be a patient, why they're going to get help, and why others don't. And this is not a matter of access to care. I'm holding that constant. But what's so fascinating about the traumatic response is how it can be shaped by the way, shaped by post-traumatic factors. In other words, what kind of messages people get in the aftermath, whether in fact what they're experiencing is normal or pathological, whether it will be temporary or whether it will be long-lasting or even chronic, what the meaning of it is to a person. There's a fascinating study of done on Turkish dissidents and political dissidents. These folks knew in their training that they might be captured and they might be tortured, and some of them were. And they were compared with a group of citizens who got essentially caught up in that net. So they too were considered to be the enemy, although they were just innocent, and they were subjected to the same brutalization. Afterwards, as you might guess from what I've been saying, the people who were prepared for this, were ideologically committed to this cause, knew that they might be brutalized. Very low rates of post-traumatic stress disorder. In the folks who had no expectation of this, no commitment to the cause, it wasn't, they say it wasn't something that was expected, high rates. I mean, and to think that you can modify the response to the same stressor so profoundly based on your psychological state is very, very interesting, and of course has tremendous therapeutic implications, therapeutic in the formal sense and also in the public health sense, the kind of messages we give to the population in the face of disaster. Let me move on to a more classically therapeutic case. This is a 22-year-old young man who was in the army in Iraq, and he was injured. He actually had a bad physical injury from a gunshot wound, and that was AK-47 IED. Anyway, and that was he was recovering from that. But as his physical wounds were recovering, he believed he was suffering from post-traumatic stress disorder. Not implausible, and in fact, he did meet criteria. So he was still in the hospital. He hadn't been even discharged from the military yet, and he was understandably hopeless about his situation. He was so tentative, so racked with nightmares, so anxious, so demoralized about his future, he thought, I'll never hold a job, I'll never have a full life, I'll never have a wife or a family, I'm finished. And so he asked to be given full and total and permanent disability from the military. And he got it. Well, actually, he had to fight for it. He got a lawyer, and he ultimately got it. This was a story on NPR, and it was actually framed as the evil military. It wasn't, it wasn't helping this man with his disability benefits. But, the way I heard it as a psychiatrist was, God, that is the worst thing they could do to this 22-year-old man, to give him total and permanent disability without giving him any treatment at all, without telling him that you're right, son, all your fears are true, and here's your check, you are totally and permanently disabled. To do that, first to give anyone that message, I think, unless we have damn good evidence they're totally and permanently disabled, is extremely destructive. It is the most demoralizing message, and it deprives people of what's probably the most effective therapy we know, which is the world of work. It gives folks an identity, it keeps them busy, and believe me, boredom is one of the biggest threats to someone who is feeling sick, even my drug addicts, if they are bored, that's a recipe for disaster. Work is a great social environment. As I said, it is an avenue for purpose. And at the very least, it's just for distraction. Because if you sit home and ruminate on your problems, that alone, as Sonia has done a lot of work on that, will show you that that will entrench symptoms and make them worse. So I thought the worst thing they could do for this young man, without ever having treated him, I mean, could you imagine having a spinal injury, and before you even have surgery or physical rehab, someone says you're permanently and totally disabled, and they take you out of the, and they basically, you sit at home, and then you are removed from the whole productive world and from a social world. And it could be that this young man would never have, possibly he would never have recovered. That's a very tiny percentage of cases that happens. But to do this to him at such an early phase, at 22, and functionally telling him his life is over, I think is a very, very, very unfortunate thing to do, almost tragic. Even people who have, I mentioned the essence of PTSD being a fear reaction that hasn't extinguished, and we obviously involve the amygdala, all kinds of neural circuitry about that. But I felt I had to mention that here. Everyone else mentioned the brain, but and that's very real. But actually, what I would focus on more is the fact that folks, and it sounds a little naive, but it's not. It's really profound. They need a sense of hope, and they need to be able to imagine a future. And the way that you can do that best for people, because so many folks can actually cope with distress and symptoms, and they do resolve on their own, or can work so much better within a therapeutic setting, is when you create those conditions for that kind of flourishing. And the conditions can be set in the most mundane ways, by economic security, by attending to that in the veterans who come back. The marital relationship is often tattered, and to focus on that. A new vocational identity, that's very important. To prevent social isolation, all these things, I know they don't sound like heavy-duty psychiatry, but and in a way they're not. They are really human ways of shoring people up after they've been through very, very difficult situations, but we don't do enough of that. Instead, we have a low threshold for going to the disability, again that message of hopelessness, and again the perverse incentive to stay ill, because the longer you don't work, your skills atrophy, your confidence erodes, and then you need the money, and you have to be sick. And there's a very big suggestive component to all this. I guess I'll sum up, but I'll just reiterate how powerful suggestive components are. Speaking of, someone mentioned the British, or you said World War II. Well, in the British Army in World War I actually forbid the use of the word shell shock because it was so suggestive to soldiers. They actually banned the word being used because they didn't want to suggest that as an interpretation to some of the soldiers. This is why in World War II especially, forward psychiatry became so common. The idea that you treat psychic wounds close to the front. Once you send someone home or take them far from the battlefield, they'll never return. In the Blitz, as you might imagine, the Blitz was very much similar to 9/11. Clinics were built up all over England, but London took it, and there was so much writing and so much amazement at the resilience and the fortitude, because that was the expectation, that was the narrative. And to close up, and we've seen the dark side of suggestion. We've seen multiple personality disorder craze. We've seen the satanic ritual abuse nonsense and the outrage with the daycare. So I'll close by saying, even though I talked about, I think, some of the deficits in terms of the way organized psychiatry often responds to folks who've been traumatized, the solution is I'm probably the one person who has an answer here, which is do the opposite. Suggest the opposite. Instead of permanent disability, instead of defect, and emphasize the challenge aspects, shore up the obvious kinds of stressors that people will have in their life when they've come back, when they're involved in disastrous situations, shore up the psychic and the physical infrastructure, and that will get you very, very far. And when it doesn't get you far enough, then formal psychiatry can come in. But these other large-scale kinds of innovations are incredibly important. And we have to focus on them more in psychiatry and, of course, in society after disasters as well. Thank you.